Welcome everyone to this afternoon's session that is run by the NIHR Complex Review Support Unit. My name is Olivia Wu and I'm the director of the Complex Review Support Unit. So today my colleagues and I are bringing this session to you. We want to talk to you about what we think is a very important step for a systematic review, identifying the right methods to answer the right questions. Now, I think we all agree that in recent years, methodological development in this systematic review world is very fast moving. I think if you just look at the Cochrane Handbook, in the 2006 edition, there were 11 chapters, and the most recent edition, published in September 2020, has 26 chapters. It's a very clear signal on how we're thinking more deeply on how to do reviews well, and also the growing number of methodologies available to us. So today we focus on two broad areas that our support unit very often have received queries on. One is test accuracy and prognostic reviews, and the other is on network meta-analysis. We're splitting this session into two parts. We'll first talk about test accuracy and prognostic reviews, and then we'll have a short break to take questions. And we would also like to hear from you who may have had done these type of reviews and session. And along the way, while our presenters are speaking, please do put your questions on chat, and then we will deal with them during our Q&A sessions. So without further ado, I'm going to introduce you to our first speaker. Our first speaker is Terry Quinn. Terry is one of the members of the Complex Review Support Unit, and many of you may know him as the coordinating editor for the Cochrane Dementia and Cognitive Improvement Group. So Terry, I'll hand over to you.
Okay, thank you, Olivia, and thank you to the Cochrane Group for asking me to share some thoughts. So what I'm going to be talking about is how we move from a clinical question to a review that has the right methods. And as Olivia mentioned, we're going to mostly be focusing here on reviews in the test accuracy or the prognosis space. So let's have a think about the typical Cochrane product. This is one of the reviews from Cochrane Dementia. It's looking at aromatherapy. It's a good review. It's one of our most downloaded reviews, but it's quite traditional. It has a small number of placebo-controlled trials. There's an attempt at a pairwise analysis, but there's not many studies to inform that. And the conclusion is the conclusion that we so often see in a Cochrane review, that more research is needed. And that's sort of the past. The brave new world for Cochrane is something more complex, and that's what we need to answer the important clinical questions. Olivia's already alluded to this, but if you have a look at the Cochrane Methods website, you'll see that it's growing all the time. And there's new groups being formed to look at different methods, including things like comparing multiple interventions, IPD, qualitative, non-randomized studies, and lots of other things that I can't put on this slide. So it's maybe unsurprising that the clinicians that get involved in Cochrane seem a bit bewildered by this. And what I want to do is take things back to basics, because the best reviews, the best evidence synthesis come from a clinical question. They come from something that we see and we think, well, that's interesting. I wonder if anything's been published on that, and I wonder if we can pull it together. So what I'm going to do over the next 15 minutes or so is talk about how we can move from a clinical thought, a clinical question you have, to something that looks more like a review title that's using the right methods. And I'm going to use some real life examples of titles that have came to us in NIHR CRSU. And I guess my two messages are going to be that if you're a bit stuck, sometimes mapping out the pathway can help you. And very occasionally, a little bit of scoping and seeing what's already been published and how those primary papers have been analysed can also help. Just as a little teaser, I'm going to share some examples of where we've taken complex methods and made them even more complex. And there'll be lots of time at the end if you have questions about anything I'm saying, because we do have a limited time to talk, and I won't be able to cover anything in lots of depth. So let's start with a clinical question. And here's a question about CLL, chronic lymphocytic leukemia. And the question is, I recognize that things like age and staging seem to tell me about relapse. If I combine them, will it allow me to predict who's going to relapse? And what we can do to work out the method here is we can map it out a little bit. So we have a population of people with CLL. They'll be receiving systemic therapy. And based on these factors, some people do, and some people don't have a relapse. So the question is, what method would we use to have a look at that? Now, we're not going to do any live polling. There isn't the time for that, but you can just have a look at the options here and have a think. If you had this clinical question, what kind of Cochrane review method would you use? So really what we're doing is we're looking at things that seem to predict an outcome, age, sex, staging. We're combining them. So we're essentially creating a prediction model. And this is very much an exemplar of the prognosis review method that uses prediction models or prognosis models. And this isn't a theoretical example. This is a real review. And we can apply the framework that we use for prognosis reviews. We'll all be familiar with PICO or PICOs. For prognosis, we change it up a little bit. So we have a population, in this case, people with CLL. Our intervention is the prediction tool. There may or may not be a comparator, another prediction tool. Our outcome here is relapse. Where prognosis differs from other methods is we introduce a time variable as well. We have to say the time at which we want to measure that outcome. So here we're looking at 1 year. And we recognize that these things differ according to the setting in which they're used. So we specify a setting, and that could be the oncology outpatient department. If you were stuck, and if you weren't sure, what you can do is you can look at some of the primary papers, and the primary papers that made this summary of findings table looked at two complementary measures. They looked at discrimination and they looked at calibration. Now, I'd never say that you want the analytical tail to wag the review dog, but just sometimes when you're stuck, if you have a look at the primary papers, it can help you decide which method is going to be best. And as I said, this isn't a completely theoretical example. This is a prognosis review that's been completed within Cochrane, and it's one of the ones that Cochrane use as a good practice example of how to do this kind of work. So let's change the question a little bit, and let's say, okay, I've got this prediction model. If I use it, is that helpful? Similar question. Again, we're talking about prediction models. What sort of method for a review would we use there? And again, I've gave you some options. Well, actually, this is an intervention here. Although we're looking at a prediction model, we're using the prediction model as the intervention. What do I mean by that? Well, we're moving from this paradigm where we recognize that some things are associated with an outcome, and we're essentially looking at the strength of that association, to something a bit more complex, where we have our population, they have their primary systemic therapy, and then usual practice would be to give more of that therapy or not give more of that therapy, and some people will relapse and some people won't. And it's a bit arbitrary, it's maybe based on clinical experience who gets what. Whereas we can introduce the prediction tool to guide who doesn't and doesn't get therapy, and we can compare the number of relapses using those two approaches. So it is an intervention, and it would use intervention review methods, even though at its heart there's a prediction tool there. So let's change the question again. We're still thinking about CLL, but now the question is, well, how many people out there with CLL relapse? Important question. Which of those methods would you use for that? And of course, it's a trick question because none of those methods are appropriate. And I just put this in to remind us that important questions that, will give an important systematic review aren't always suitable for Cochrane. Cochrane have a particular remit for particular reviews, and some reviews don't fit quite well within the Cochrane model, but that doesn't make them bad systematic reviews. Okay, so let's move from CLL to another area. We're looking at MS now. And the question is, can I use clinical features to tell me how someone is going to respond to immunotherapy in MS? So again, we can map this out, and the map looks quite similar to the previous example. We have people with MS, they get immunotherapy, and based on certain factors, that seems to tell you who will and won't relapse. So again, this is a real life example. This group came to us. Which method did we use for their review? Well, you may think, and we originally thought that the right method here would be, again, the prognosis model. But this is a good example of where sometimes if you just do a little bit of scoping and look at the data that are available, you maybe will change the review method that you want to use, because actually the papers that were available didn't use a prognosis model approach at all. What they did was they had subgroup analyses of trials. So they had trials of immunotherapy, and then they looked at, for example, older age versus younger age as a subgroup. Or they looked at severity of MS as a subgroup and looked at rates of relapse. So actually, for this review, we went back to pairwise, but we looked at lots of subgroups. And again, this is a real example of a review that came to us. So let's move now to some things that came through my group in dementia. And here's a clinical question. Medications that have anticholinergic effects, people say they're associated with dementia. That's often headlines in the press about medications that are associated with dementia. So let's map this out. What we're saying is you have a population of people who have no memory and thinking problems. In theory, if they're exposed to anticholinergic medication, they may develop cognitive impairment, memory and thinking problems. And if they continue to be exposed, they may or may not develop dementia. And here is one of those cholinergic burden scales. It looks a bit overwhelming because it is, but essentially you have long lists of medications and each one is assigned a score of 1, 2, or 3, and you can calculate the cumulative burden of anticholinergics for an individual. So what sort of method would we use here if we're thinking about anticholinergic burden and risk of future dementia? Well, again, looking at that big list, there's lots of things there. So you might well think, well, this is a model and taking lots of factors and I'm combining them. But actually, that list is a single thing. It's a single construct. It's anticholinergic burden. It's measured in lots of different ways, but what you get is a single figure, a single exposure. So in fact, what we're doing here is we're looking at the other kind of prognosis review. And again, we can get a clue about that if we look at some of the primary papers, because the primary papers just looked at the size of an association. They predicted things like odds ratios, hazard ratios, risk ratios. And you can see how that differs from the prediction models that looked at calibration and discrimination. And again, this isn't just a theoretical example. This is one of our prognosis factor reviews that we are publishing within the dementia group. So let's stick with dementia, but let's ask a different question now. If you have memory and thinking problems, or if you're worried about dementia, you can have a spinal tap. People can analyze your cerebrospinal fluid, and they can look for markers that might suggest that you're at risk of dementia. So we can map this out. We have people with dementia. They can have their CSF measured and look for these biomarkers, or it might be people that already have some symptoms, and they can have their biomarkers measured. And in theory, these biomarkers should help you determine who will and won't develop dementia. So what sort of method might we use there? Well, we have a whole suite of these reviews. And what we did at the time was we looked at test accuracy. With hindsight, that may not have been the right approach, but I think it was the right approach at the time because the tools weren't there for us to apply any other approach. It was test accuracy evidence synthesis that we understood. Some of these reviews are 5 and 10 years old. But actually, if we look back at our map, we can see the exposure here is separated in time from the outcome. And in fact, the separation in time can be decades. Some of these biomarkers are being proposed for use in middle age to predict a dementia that might happen when you're 70 or 80. So the test accuracy paradigm maybe isn't quite right here. And actually, with hindsight, what we should have done is looked at these using the prognosis factor lens. And that's what we're going back to do now. We're going back to these reviews and we're going to update them, but we're going to change from diagnostic test accuracy to prognosis methods. Okay, so let's stick with dementia, but here's a different question. If I do a questionnaire or a pencil and paper test of memory and thinking, and the person does badly on it, does that mean that they have dementia? So we can map that out. It's a much more simple map. We've got people who were worried about their memory and thinking. We perform our test, our assessment, and some will, some won't have dementia. No variation in time. This is all happening at the one time. So no prizes for guessing that the method that we used here is a test accuracy method. And again, we have a whole suite of these reviews looking at different cognitive tests and looking at their test accuracy. And we can apply the standard here. We're moving from PICO or PICOTS to something a bit different. We're looking at an index test, the test that you're interested in. And in this case, it'd be one of the many cognitive screens that are available. And then we compare that to a gold standard, perhaps more better called a reference standard, which in this case is the clinical diagnosis of dementia, which we're using to diagnose a condition of dementia. And again, we specify the setting in which all of this is happening. So for example, we could look at how these things work in the acute hospital setting. And if you scope out the primary papers, what you'll usually find is that they have these complementary measures of sensitivity and specificity, which again gives you a clue that you're working in the test accuracy space. And here I just want to do a bit of a plug. So we've had lots of approaches from people working on test accuracy reviews, and one of the stumbling blocks for them was actually performing that final analysis. And so we've developed an app. It works with RevMan, and it allows you to produce that quantitative synthesis of summary estimates of sensitivity, specificity, ROC curves that you need for test accuracy reviews. And if you're interested in the app, we can give you the details of that and tell you more about it in the Q&A. So what we've looked at there is a single test, but actually in clinical practice, the problem that you often have is you've got lots of tests available. In dementia, there are literally hundreds of different memory and thinking tests that I could use in the clinic. So which one is the best? And what method would I use for a review looking at that question? So we have lots of reviews on single tests, and I can fairly confidently tell you about the accuracy of the mini mental state examination or the accuracy of the Addenbrooke's cognitive examination. But knowing those accuracies in isolation actually isn't so helpful to me. What I really want to know is one better than the other? So the method that we want to use here is test accuracy, but it has to move beyond that conventional paradigm and start to look at comparing tests. And because there aren't many primary studies that compare more than one test in the same population, one of the things we've been doing has been developing techniques for indirectly comparing the test properties of different assessments using a network. And again, there isn't time to go into the details of this, but it's just one of those examples of where we've taken a complex method and we've tried to add on another level to really help us answer the questions that are clinically important. But again, if you're interested in this, we have a whole panel at the Q&A that can answer questions on this particular method. Okay, we're almost done. My last little thought, my last little clinical question. If I perform one of these memory and thinking tests and the person does badly or screens positive, does that mean they have dementia? So we spoke before about this, but it's worth just giving it a little bit more airspace. So in dementia, you have a progressive condition. You can have people who you're worried about their memory and thinking. You can perform your test or your biomarker, and they may or may not have a clinical diagnosis of dementia. The complexity is that the people that have the clinical diagnosis of dementia don't always have dementia when you look at their brains. And there's a disconnect between the clinical diagnosis and under the microscope, the neuropathology. So really what we're talking about here is test accuracy, but the reference standard that we use, because we can't get brain material on everyone with suspected dementia, is imperfect. There's variation in it, and it maybe doesn't completely capture the condition that we're interested in. Very common in test accuracy research to have this imperfect reference standard. And again, just as a little teaser, we have been doing some work on this as well. So what I have here are estimates of the inter-observer variability of different ways of diagnosing dementia. And I just show this to you to show that it's there. And actually, for some methods of diagnosing dementia that are called the gold standard, there's quite substantial inter-observer variability, which says that there must be some erroneous diagnoses being made there. And again, just as a little teaser, but if you want to know more, ask questions in the Q&A. We've been doing some work about how you can try and incorporate that imperfect reference standard into your analysis. And here we have an example of where we've applied this to the diagnosis of deep venous thrombosis. But really, I just show it to make the point that when we assume that the reference standard is perfect, we can sometimes over or underestimate the true properties of that test. So I think going forward, we need to think more about how perfect is our, in inverted commas, gold standard. Okay, so I'm going to stop talking there. Hopefully some of what I've said has just got you thinking, and maybe thinking about a review that you'd want to do that would maybe use some of these methods. If you are thinking about such things, and if you want to get in touch with us, our details are on the slide here. And the method that I would the message that I would always give is get in touch with us early on, because what's always a bit of a heart sink is when a review group have done lots and lots of work and have taken the review so far, just to then find out that maybe they were using the wrong method and they were on the wrong track with the review. So thanks for listening. Hopefully we've generated some questions. At this point, I'm going to hand back to Olivia.
Thank you, Terry. So we now have some time for a panel discussion and also for us to answer some of your questions. So you'll see on the screen, today we have, including myself, 7 members of the Complex Review Support Unit here. We all do work in both diagnostic test accuracy reviews, prognostic reviews, and network meta-analysis. So we really would like a lively chat with you and also to try and answer some of your questions. So there has been quite a few questions coming in already, and I'm just going to go straight to it. Now, Terry, I absolutely agree with you, and we see this a lot. And the first part of thinking about how to approach the review is so important. And I think often people underestimate how much time they should be spending on this. And the way that you've laid out your pathway diagram is really nice. It really helps you think about the actual problem. But you talk in your examples. You talk a lot about the potential different problems that may result in you on the choice of the methodology. Sometimes it's really thinking about what you're asking, and it could be to do with the data. And so one of our participants is asking, are there any resources available to help reviewers determine the right approach? Such as health economists often use decision trees type approach. What are there any resources out there, or do you have any top tips for us?
So I'll share my thoughts, but I'm sure other people on the panel will have thoughts as well. The little pictures that I showed, those little schematics, they look very simple, but they help me think about things. Because I guess one of the fundamental differences between diagnosis and prognosis is about time, and whether that there is the passage of time between the exposure and the outcome, and that the diagnosis and prognosis primary research and reviews are quite blurred. But I think if you try and map out exactly what's happening, that often helps me. If I'm allowed to plug CRSU a bit more, we also have some resources on our website. So we have some resources about test accuracy, and we have some little apps that you can play with as well that can maybe just help you inform your thinking about whether the area you're interested in is truly diagnosis or truly prognosis.
Thanks, Terry. And so another question is about how do you know if you're not doing, if your approach is not right? So so some people do come to us, and then we can help them, either to give them confidence that they are actually along the right track, or we'll give them advice on how they could approach things differently. But many reviewers might not know if they've gone down the wrong track. So are there ways to self-check, perhaps, to find out, to give you a signal, perhaps, this is the time to pause and think about this again?
Sure. Well, again, I'll give my thoughts, but other people do chip in. So once you have your title and you have an idea of some of the papers that you think are going to be included, you can kind of create a little ghost draft of what your summary of findings table might look like. And you can just think, are the papers that I have that I know are relevant to this question that I think are going to be included in the review, will they allow me to fill in that kind of summary of findings table? So there's a template summary of findings table for prognosis, for diagnosis, for interventions, and you can just think, can I get from A to B with these papers that I think are going to be in my review? Will they allow me to complete that table or not? And if you find that there's a disconnect between the two, then you maybe need to take a step back and think, am I applying the right methods here?
So what about the other members of the panel? Does anybody want to add anything to what Terry said already? Okay, so we've got another two questions on the DTA app. So for interest on the app, where are we going to find the app, and just a bit more information about the app. So I can tell you where you can find these apps. So there's a link to these apps on the NIHR Complex Review Support Unit's website. So you can find it there. But perhaps I can ask Enzo. So Enzo Chirullo is one of the members of our team, and he's done a lot of work in developing the diagnostic test accuracy app. Enzo, do you want to say something about what the app can do?
And yeah, so the diagnostic test accuracy app MetaDTA, that was actually done by Suzanne, and that can do the sort of standard bivariate model. So that's for assessing the accuracy of a single test for a meta-analysis. And it gives you the summary receiver operating characteristic plot for that. So you can use those in manuscripts, for example.
Thanks.
Olivia, can I just add that in MetaDTA as well, we've also integrated the quality assessment into the data entry. So you can also have a look at your summary ROC curves and display the quality assessment data for each study at the same time. So you can have a look at maybe how that quality assessment is impacting your results. And sensitivity analysis is really easy, because you can go to the sensitivity analysis tab and you can just select studies to exclude, and the app just automatically updates for you there and then.
I think the other thing to add is these apps are constantly being developed and updated, and so if you have used the app and you've got thoughts on how the app can be improved, or additional functions that would be really useful, then do drop us an email or send a comment through our website, so that it will help us prioritize our development of the app. And so before we move on to the next session, the final question, so I think this one perhaps Alex and Nicola might want to answer. We've supported many DTA reviews over the years, so we've been in operation since July 2015. And the question is, what is the most common error you've seen in supporting review, authors. And but I'd like to say that, you know, we don't really see errors. You know, people come to us when they're stuck with problems, and perhaps I will I will change the question to what is the most common inquiry that has come to us, and so, you know, what more can we do to address this? So rather than, you know, having people to be stuck on something and then come to us, is there something that, you know, that we can advise here, so that they can overcome this?
Do you want me to have first go? Okay. I think that one of the first things is that there's difficulty in interpretation, even when you can fit some of the models and how to present the results. So I think that's a challenge. And hopefully, I mean, that's one of the reasons we developed the app. People struggle with the analysis and interpreting results, and we've tried to make things visual there and give some info on that. I mean, from my point of view, what's the most difficult thing that I encounter is that there's often great heterogeneity in these reviews, and it's quite challenging to even sort of set up the models to start exploring that, and often they're not that straightforward to you know, interpret and explain. So in terms of the analysis, it's those things, and indeed the next version of the DTA app, we hope to be able to incorporate covariates to make that a lot easier, because we kind of identified that as the next step forward.
Yeah, I'd just reiterate, you know, a lot of the time, if they've decided to go down the route of diagnostics, it's the actual implementation and understanding their data, and maybe doing some exploratory before jumping into the meta-analysis itself, like Alex said, trying to explain and understand the data before trying to actually do the meta-analysis itself. I think it's really, really important.
Thanks, Nicola. So we've got a few more questions, but in the interest of time, I think we'll move on to part two. But please remember, we're here as a support unit. So if you're working on a review that you would like some advice on, or just even to have a chat with us, then just get in touch with us. So the second part of this session is on network meta-analysis and component network meta-analysis, and our unit definitely have supported a lot of these type of reviews as well. So I'm going to hand over to Suzanne and Neil. So Suzanne Freeman is a research associate at the University of Leicester. Neil Hawkins is based at the University of Glasgow. He's the Deputy Director of the Complex Review Support Unit.
Great, thank you, Livia. If anyone from the technical team is listening, I don't have control of my slides, so I'm unable to change the slide. So, thank you. So I'm going to start by talking through a pairwise network and component network meta-analysis, and then I'll be handing over to Neil, who will talk through some examples. So I think pretty much everyone in this audience should be familiar with the idea of a pairwise meta-analysis, where we take a series of clinical trials, all comparing the same two treatments, and we're looking at answering questions such as, is treatment B more effective than treatment A? Or what is the effectiveness of treatment B compared to treatment A? So if we can go to the next slide, then on this slide, you can see here, I've created this hypothetical scenario for network meta-analysis. So I've got 20 blue boxes here, which represent 20 clinical trials. And in this particular network, I've got 5 treatments, A, B, C, D, and E, and each trial is comparing different combinations of those treatments. So on the next slide, we can redraw those 20 blue boxes into a network diagram. So what we can see here is we've got each treatment is a treatment node in the network, and then we've got solid black lines connecting those treatment nodes where we have direct head-to-head clinical trial evidence. So we've got 5 trials comparing treatment A with treatment B, and 6 trials comparing treatment A with treatment D, but we don't have any direct head-to-head evidence comparing treatment B with treatment D. So now the advantage of network meta-analysis is that it allows us to compare every treatment in our network to every other treatment in our network. So by analysing this network using network meta-analysis methods, we can get an estimate for treatment B compared to treatment D. So with network meta-analysis, we can answer questions of the form, which of these treatment options is the most effective, or even which of these treatments are effective, and also what is the comparative effectiveness of the treatments A, B, C, D, and E. So moving on to the next slide, this compares this pairwise and a network meta-analysis approach. So in a pairwise meta-analysis, we've only got our 2 treatment options. So if our research question, for example, was of the form, does any form of intervention reduce the outcome of interest? Then we may find that we lump together some interventions and compare all of those to control. However, we could also split out those interventions into separate treatment nodes and analyse that as a network meta-analysis. So sometimes pairwise meta-analysis can be referred to as a lumping approach, whilst network meta-analysis is a splitting approach. With a pairwise meta-analysis, we can perform this with at least two studies, whereas a network meta-analysis, there is no hard and fast rule on the number of studies you need, but I think a useful rule of thumb is to have at least as many studies as the number of treatments in your network. And a network meta-analysis also requires a connected network. So if we can go back a slide, then what you can see here is a connected network, because each treatment node in the network is connected to at least one other treatment by direct head-to-head clinical trial evidence. If we removed the 2 trials connecting treatment A and treatment E, we would no longer have a connected network for all 5 of our treatments. We would just have a smaller network looking at A, B, C, and D. If we can move on a slide and on again, then component network meta-analysis is a newer approach that has sort of really increased in popularity in the last few years. And so I'd like to sort of explain this approach by thinking about this example of psychological preparation for adults undergoing surgery to reduce length of stay in hospital. So on the right-hand side of the screen, this is the network diagram for this particular review. And what we can see here is we've got 20 interventions in total, but 15 of those interventions are actually made up of multiple components. So we can see, for example, that we've across these 20 interventions, we only have 6 components that are across the network. So the advantage of this is that whereas in a network meta-analysis, we would be fitting a model with 20 treatment parameters, we can now fit a component network meta-analysis model with 6 component parameters. And when we fit these models, we have this assumption of additivity. And what this means is that even though we're only estimating 6 component parameters, we can still estimate the effects of all the treatments by adding the effects of the individual components. So for the combination P plus S, we get that intervention effect by adding the component effect of P to the component effect of S. We can also relax that additivity assumption by including interactions to allow for synergistic or antagonistic effects. And the advantage of this is that we can also estimate the treatment effect, the intervention effect for interventions that consist of components that haven't necessarily been directly compared in trials yet. And that has the potential to inform sort of future research agendas. So on the next slide, you can see that some of the questions that we could answer using a component network meta-analysis approach take the form of which components of these multiple component interventions are most effective, or what would be the predicted effectiveness of a particular combination. So on the next slide, I've compared the 2 approaches. And as you can see, a component network meta-analysis approach is only going to be suitable if our treatments consist of components and we have these common components across studies. The focus of the question of interest switches from, in a network meta-analysis, being about which treatment is most effective, So in a component network meta-analysis being about which treatment component or combination of components is most effective. And if we go back to the previous slide, in the psychological preparation example here, what we have is, if we look at the treatments, quite a lot of the pairwise head-to-head comparisons in this network are informed just by single trials. So if we fitted this as a network meta-analysis, because we'd be estimating 20 treatment parameters, we may get a lot of uncertainty around those treatment parameters. But by fitting it as a component network meta-analysis and estimating 6 component parameters, we can reduce that uncertainty around the component effects, which then can filter through into the treatment effects through our assumption of additivity. So if we just go back to the next slide, just final point to say that we can predict those optimal combinations. So I'm now going to hand over to Neil, who's going to talk through a couple of examples.
Right. Thanks very much, Suzanne. So the next few slides, actually, we're going to go back over the previous ground, but just look at some real life examples to try and illustrate what's going on. I've just clicked on my clicker, but it's not moving. Has somebody got control of the clicker? Oh. So these are examples. There are 3 different analyses which were looking at treatments for promoting smoking cessation. So we can actually look at different analyses which were done in the same kind of clinical area and look at how they vary, and also looking at, going back to kind of Terry's points, how they might answer subtly different questions. Can you go to the next slide, please? The next slide. So this is an example of a conventional pairwise type of analyses, where in this case we've got a series of different analyses comparing 2 different treatments in each case. Can we click on, I think a pop-up will, yeah. So just this is what we're very familiar with. So this is looking at counselling versus control, and gives us an estimate of relative effectiveness between these 2 interventions. And here in smoking cessation, there's quite a lot of different interventions, so we get a lot of different pairwise comparisons. Now, how useful they are depends on what question you're trying to answer. If there's a particular pairwise comparison you're interested in, you have a patient or a group of patients, or not patients in this case, but people smoking, and there are those you only have 2 options to choose from, and you might find a perfect pairwise comparison to answer your question. But it's quite possible you have more than 2 options to choose from for a particular group of smokers, and then you're struggling to know, well, I might know that compared to control, all of these options work, but which one is the best? And pairwise comparison doesn't really tell you that, although you might be tempted to kind of informally compare estimates of effect size within these pairwise comparisons to try and compare between different interventions. It's also worth noting that there is an assumption here that within a pairwise comparison that we can combine these studies in some way which gives us a meaningful overall effect estimate. So there is already some assumption of exchangeability within these studies in a pairwise comparison. It might be relaxed a bit if we have a random effects analysis, which allows for the true effect to vary, but there's still an assumption within a pairwise comparison of exchangeability. And strictly speaking, we cannot say anything comparing across pairwise comparisons. Go to the next slide, please. So let's go to a network meta-analysis. Next slide, please. And next slide, please. So now we've taken our network of trials looking at smoking cessation interventions. They form a connected network. We can do a network meta-analysis, and now actually we can compare a whole bunch of different interventions against each other. We can compare active intervention versus active intervention, and each intervention placebo. We can potentially rank them according to estimated effectiveness, and we can look at uncertainties in those rankings. So now actually I've got information which allows me to choose between a bunch of different potential interventions, which allows me to answer a wider set of clinical questions, but at a cost. And the cost is that the treatment effects are consistent, they're exchangeable, I can compare them. So if I get a relative risk or an odds ratio of 2 comparing intervention A versus B, and odds ratio of 3 comparing intervention C to B, I can make a comparison between those odds ratios and make the comparison between B and C, whichever way around it was. So I've got now an analysis which is more powerful because it allows me to compare multiple interventions, but there is a cost. I'm having to make a stronger assumption. But I can test that assumption, and it's a very useful assumption if I can convince myself and convince others it applies to a reasonable extent to my trial data. So now I've got an analysis which allows me to compare simultaneously multiple interventions, but at the cost of this exchangeability or consistency assumption. Next slide, please. So we're going to go on to finally to the component analyses. Next slide, please. And next slide again, please. And next slide. So this is an example of what the output from a component meta-analysis looks like. And now instead of having particular interventions, and these interventions might be, strategies which might combine different interventions like, I don't know, behavioral interventions versus nicotine replacement therapy or whatever. We've now got analysis which separates out those components. And we get estimates of effect for each component compared to a reference component, which here is kind of minimal intervention. So nicotine replacement therapy, our behavioral therapies are all compared to that component. And we've kind of pulled apart those strategies. Now, this is really nice. It's got potentially I can make predictions for the efficacy or effectiveness of strategies which have never been tested in the trial. I can put together these different components and make a prediction. Also, because of the way it makes the data, using the data, it's very efficient because where into those components are in multiple trials, we get multiple estimates of its contribution. But again, this comes at a cost, and it's an even stronger assumption now. Not only am I saying I can compare the effects of treatment effect estimates of comparing strategies across trials, I'm now saying that I can predict what would happen when we put these components together. But in this case, that the odds ratios will be combined. So if I put these two, and the odds ratio for a NRT component, and I've got an odds ratio for the behavioral component, if I multiply those two odds ratios together, that gets me the effectiveness of NRT plus the behavioral intervention together. So it's a stronger assumption. Now, sometimes we can test this assumption by comparing the estimates from different combinations to see if they fit our model of the way we combine them. So we can try and test this. And it's and if we can convince ourselves and others that this is a reasonable assumption, it's very powerful because we're using the data very efficiently, and we can make predictions for strategies that we might like to try which have not been tried before, but at a cost of a slightly more stronger assumption. There's kind of an intermediate because we can put interaction effects in these models that then start relaxing that assumption, but then you need a lot of data to be able to fit and estimate those types of models. Okay, to the next slide, please. So in summary, there are a number of challenges and practicalities. One is software. So things like NMA and CNMA not currently possible within RevMan. There are different approaches. Do we use a Bayesian approach? Do we use a frequentist approach? Does it matter? If we're using Bayesian approach, can we get, should we use informative priors? Range of different software, RState, Winberg's, MetaInsight, all of which can potentially fit some or all of these models. And there are issues in coding, especially in component meta-analysis. It's quite important what we choose to be that reference component. And when we get into meta-regression, it then becomes quite important what we choose to be our reference component, because that influences how regression potentially works. I think Susan mentioned that defining components can be complex, and I suspect that was an issue in the smoking component meta-analysis that Susan Freeman was involved in. Not always possible to assess consistency between direct and indirect evidence, not always possible to test all the assumptions which are embedded in the component network meta-analyses. So, and then there are issues about how you present results in a meaningful way as those networks get large. But these are very powerful techniques if we feel, and it's an empirical question, that these assumptions being used in these techniques are reasonable and help us to make useful predictions and useful assessments. The assumptions don't have to fit perfectly, they just need to fit well enough that these models and analyses are useful in decision making. I think that's the end of the slide. Susan, is there anything else you wanted to add?
There's one final slide.
Go to the next slide, please.
So, so this final slide just contains a few resources which we thought it might be useful to point out. The Cochrane Learning Live website has a whole network meta-analysis webinar series, which includes webinars on using Meta Insight, which is the CRSU app, using the Cinema app, as well as one on component network meta-analysis. So if you're really interested, I do suggest giving these a view. I've put the link to the Meta Insight app there as well. And of course, the new Cochrane handbook has a whole chapter on undertaking network meta-analyses. So I think the final slide then is just the contact details again, and hand back to Olivia.
Thank you, Suzanne. So I'm glad that you mentioned the software issue, because there was a question on software, and so the Meta Insights app is our app for conducting network meta-analysis, which we developed in parallel with the diagnostic test accuracy app. So again, you can get access to both apps through our website. Now we've got a little bit of time left for questions, so let's get the panel back together for final session questions. So there was a really good question about component network meta-analysis and complex interventions, in particular public health interventions. Now I know some of my colleagues here have actually done component network meta-analysis using of public health interventions. So. So does any of you want to talk a little bit about how it works, and perhaps talk a little bit about an example that you may have done?
I can talk about one that is being done. I've not got a direct involvement in it, but looking at things like accident prevention around the home, and you are trying to increase the uptake of safety equipment to prevent these accidents, particularly in young children. And you may have a multifaceted approach to doing that. You may have somebody come and inspect a house. You may go as far as giving equipment or giving vouchers or something for reduced cost equipment. You might even get free fitting, and obviously all these parts of an intervention may have effects, and it'd be important to know how when you put a package together like that, which of the parts are the most important, and indeed when you push on into cost effectiveness, there can be very different differences. So yeah, I think these methods, it's interesting, as the complex review support unit, we seem to be recommending these methods to people quite frequently, because I thought this was a little bit of and this is a special case of the network meta-analysis model. It seems more than that. It seems to be relevant in quite a lot of places, and clearly I think there's a lot of scope in public health that's probably not been tapped into yet.
Okay, so we have another question here on updating reviews. So I think Terry, you mentioned this. You know, on one occasion you update a review and actually you realize that there's a better approach to how you address that, and so if you do that, what implications do you think it will have on these reviews? You know, or does it not have any impact?
Well, I guess it depends on how much of a change you're making, because at one end of the spectrum, you might move from one method to a completely different method. So for example, I mentioned that we have a suite of reviews that really used the test accuracy framework, but we're going to repeat them and we're going to use the prognosis framework. So for those examples, we're starting from scratch. You know, for another example, if I can give you an example in our group of where we're using component network meta-analysis, one of our most accessed reviews was looking at the features that can be used to prevent the condition of delirium. And in its original iteration, we just had a black box that said multi-component interventions seem to work. But now, as there are more primary research studies, we've applied the component approach to it, and it's been really interesting unpacking the black box and seeing, well, actually, within these multi-component interventions, there are some things that seem to really be doing all the work, and actually there are possibly even some things that people use that are harmful. And I think that's really interesting going forward, because then you can imagine the next primary research study informed by that perhaps creates the perfect multi-component intervention based on the data that's went before.
Yeah, and I think often you're essentially asking slightly different question from the original review, aren't you? Okay, so I've got a couple of questions here asking how the CRSU operates, especially thinking about the Cochrane Methods Support Unit. So I can say that this complex review support unit works in parallel with the Cochrane Methods units, and we do have connections with all these units, and many of us have worked with members of those units on in a different capacity. And I know some of us have commented on the recent NMA new chapter in the Cochrane Handbook as well. So we're not in competition or in isolation from the Cochrane Methods Group, and also the Method Support Units. We're working together, and we often share ideas or challenges that come across that come to us, and we share those as well. So if you need help with your review, you can definitely either go to the Cochrane Methods Support Unit or the Cochrane Methods Group or ourselves. I think we're just all here to help you. Right. Then there's another question on how many inquiries do we deal with per year. Roughly, I think we deal with perhaps on average about 20 reviews a year, but so every review is different. So some reviews come to us, would only require a teleconference, and we go through some of the challenges they're facing, but other reviews might require more attention, and we will work with them over a period of time to help them shape the question, develop the protocol, or try and troubleshoot the analysis that they're undertaking. So every query that comes to us are different. It's hard to think of a standard type support. Right. Okay. So I think we're almost out of time. So I just want to thank my colleagues for the session, and also, most importantly, to thank you all for coming along and all the questions that you've asked us. It's really nice to have some interaction with you all, even though we're now in a virtual world. If you want more information on the unit, please go to our website. And if you want to get in touch with us with inquiries, just drop us a note. So thank you again, and enjoy the rest of your afternoon. Bye.